All right. I think we'll go ahead and get started. Let's see here. All right. Hello, and welcome to the our C19 Great Lakes Learning session. And Avery Jackson and Karen Marie Jackson, as you all know, and we're excited to have you guys. We'll introduce our speaker in just a second.
It's great to see familiar names and faces. Yeah, we're all body members joining. And
I'm sorry, Michelle, can you make us host if you don't mind, or co-host, or both, or one, or and then
and just to
thanks.
Let everyone know that we facilitate other sessions if as body members, though these CME CEU sessions are part of your monthly subscription. So for one category 1 CME or CEU credit, you will get information after tonight's session as far as filling out a short survey and then obtaining your certificate of attendance. So in the other sessions that we facilitate, all offer CME or CEU credit, except our Healthy Lifestyles, which is a non-CME session that is generally it's the first and third Thursday of each month at 8 p.m. Eastern Standard Time. Sometimes that adjusts a little bit depending on topic and timing, but that's monthly, and we're a lot more free at those times usually to talk about favorite brands that we like to use of different supplements, because that's always very, very helpful. So and then we put in the chat there as far as the credit for tonight. But our other sessions that we facilitate are addiction medicine, chronic pain, and mental health session that takes place on the second Friday of every month at 12 noon Eastern Standard Time. And so our next session for that is actually, I don't have my calendar out, so I'm going to have to update update soon here. But our we also facilitate a session that revolves around osteoporosis management, treatment, prevention, and that takes place on the fourth Friday of every month at 12 noon Eastern Standard Time. So that is this Friday. And Dr. Richard Ammerling so kindly opted to lead that session for us on renal bone disease. So that should be very excellent, lively. And then our DPC functional medicine session that takes place on the second Monday of each month at 6:30 p.m. Eastern Standard Time. So our next session for that is going to be Monday, October 14th. I think I have those dates right. So the whole, purpose of these sessions is to facilitate interaction. We all learn from each other, especially with member care. We definitely want to make that a priority. So if there's something that you are using that's very helpful that you're finding in your clinic or practice, we definitely want to know about it. So we always really emphasize the interaction. So and because of the wonderful interest that we had tonight with our speaker, which is just fantastic, I think we might need to bypass individual introductions just based on the time. But definitely, if it's your first time joining us for one of these sessions, if you can please feel free to put in the chat where you're joining from. And if working, what your profession is, we would love to know that. And then after when we do Q&A session, you can certainly introduce yourself at that time. So we really like to see everyone and who's joining as we get into the interaction part of it. So with that, I am going to let you introduce our illustrious speaker.
Right. Yeah. And so obviously, Stefan Hartmann, PC, he's a German American, and
he needs no introduction.
No introduction. Really cool guy. And he has been raised by holistic parents and Chinese medicine and Tai Chi, which is my favorite, among other things. And he attended University of Central Florida, and actually is huge. Dealt with was a national championship team for that, and also in the emergency department. He did some day-to-day work, which was really cool. Magna cum laude, bachelor's sports exercise science, and master trainer in LA Fitness. He's done a lot. I mean, I could, anyway.
You didn't mention tennis.
I did mention tennis, the national championships, right?
Okay, yeah.
And so also he's been adept at internal medicine and surgery, interventional pain, family medicine, and psychiatry. And so really interesting sports background, exercise science, which is really cool. And so, there's a lot that Stefan has done and is teaching his students as well as us, which has just been great. And so
his emphasis on prevention,
preventative
health.
That's right. Preventative health is huge.
Yeah.
And so with that, and I really want to get some time for him to talk because there's going to be a ton of questions. So Stefan, you have the mic, sir.
Great. All right. This will be a fun lecture tonight, and a really practical one here that everybody can, take home some really practical information here. Because what we're going to talk about tonight is super common, and it's congestion and mucus. I would say that was the #1 complaint I saw in my years working in urgent cares and emergency departments. It was respiratory related, especially in the urgent care. I mean, #1 complaint. After that, it was probably maybe back pains and UTIs, but respiratory. Everybody gets congestion. But in school, we really didn't learn how to treat congestion. We learned how to rule out a pneumonia. We tried to figure out how best to use or not use antibiotics. But what ends up happening in urgent cares is everybody gets an antibiotic out the door. And we're going to learn a bit about why some patients say Z-Paks, they swear by a Z-Pak, they swear by a doxycycline, and why even providers gravitate towards these things. There is some mechanism behind why these work. However, we know these things wreck the gut. We know they deplete vitamins and nutrients, have long-term consequences. If we use antibiotics indiscriminately, at some point, society won't have the option to use antibiotics anymore because of the antibiotic resistance. Enter nebulized acetylcysteine solution. I discovered this one early on in the pandemic when I was trying to figure out how to help people. There wasn't any protocols. This was before the FLCCC came around. That didn't even exist at this time. And I was searching for these sort of things, how to help people. And I actually asked a lot of functional medicine folks at the time how to get this. And they're like, oh, we don't know. It's impossible. This is a commercially available medicine. So that's how you're going to learn also how to get it, practically how to and get this thing. So let's talk about what this thing is, or the foundation building blocks. It's acetylcysteine. It is an antioxidant. It's been known since the 1960s. It's an amino acid. It's the precursor of glutathione, but the building blocks of glutathione also require glycine. So many of my patients, they'll take oral NAC and oral glycine every night to support their own glutathione production. So if you have a couple of these building blocks, you produce glutathione. Now, glutathione and NAC, these are depleted in severe illnesses like COVID-19, mold, Lyme, anything that's burning through your antioxidant reserves. So the history of NAC, in the 1960s, it was discovered for respiratory disease. It was commonly, as we'll see, used IV for Tylenol toxicity overdose as the classic treatment. That was actually the only the only education I got in acetylcysteine back in school was for Tylenol overdose. I was like, oh, it's the antidote for Tylenol toxicity. It is acetylcysteine. And that was like the end of the story. But there's a lot more applications for this thing, as we'll find out here. Right? It serves as a substrate for glutathione. It reduces formation of pro-inflammatory cytokines such as IL-9, TNF-alpha. It also has vasodilatory properties, increases cyclic GMP levels. So there's a lot of reasons why we might use this in COVID-19, specifically COVID-19 sort of lung disease or any sort of respiratory diseases, because those diseases attack the lungs. So we want to get an antioxidant into the lungs. Sure, you can take it orally, great, but we want to get it directly targeted to the tissue that's under stress. So let's look at some of these studies here, because it's relatively unknown, even in functional medicine, how to use this thing, and especially not commercial medicine. But it's been studied, and it's been often studied in combination with bronchodilators for about 70 years now. And the reason they use it in combination with a bronchodilator is we're going to learn that sometimes patients with severe lung disease, they'll get a little of a bronchospasm associated with this, especially really sick people, cystic fibrosis patients. That's where this was traditionally used, this nebulized acetylcysteine form. So it was commonly combined. We'll see a lot of studies, they'll combine it with a bronchodilator. But NAC is a mucolytic agent. And it's been acknowledged to a couple of big names: American Thoracic Society, European Respiratory Society, and so forth. So here's a picture of bronchioles. Look at that one down there on the bottom right. It's a chronic bronchitis. It's a swollen bronchiole. It's full of mucus plugging. We want to fix this for a patient. So the conventional treatment, maybe they give them an antibiotic or they give them a steroid for this, but it doesn't relieve the mucus. And it's only acetylcysteine that will actually reduce the mucus plugging. So here, bronchial obstruction previously observed with acetylcysteine alone did not occur. Oh, hold on. I'm jumping around here. So these patients, they were given racemic epinephrine in combination with acetylcysteine, and that will help the bronchospasm in association with this. So the racemic epinephrine is commonly used for croup. So you can use acetylcysteine solution in combination with racemic epinephrine to treat croup. These patients, their classic croupy cough, seal barking cough, is kind of classic. You can hear it down the hall in the ER. You don't even need to see the patient. You know they have it. It's that obvious sometimes. I used to, before I knew about acetylcysteine, I used nebulized saline, but as this study kind of showed, it actually makes the sputum a bit worse and thicker. So I got away from nebulized saline, even like 7% solutions, a long time ago after I discovered nebulized acetylcysteine solution. So here's a little bit of the mechanism behind why you would use nebulization of acetylcysteine as a COVID-19 therapy. And it's because the COVID-19 causes a lot of attack on the lungs. It causes a fibrosis of the lungs. There's a lot of inflammatory response that goes on in the lung damage with COVID. So we give the antioxidant, and it reduces the reactive oxygen species. It helps protect the cell membranes in the lung. So low glutathione status will influence more disease, or it may just be that more diseased persons will have lower glutathione. This is well known. Diabetics will have lower glutathione status. Patients with chronic multiple stealth infections will have lower glutathione. I've seen this in practice a lot. So these patients will require more aggressive treatment with our antioxidants, specifically our acetylcysteine and our glutathione. The treatment of pulmonary diseases and respiratory-related conditions with inhaled glutathione. Now, I've never actually discovered where to find inhaled glutathione. I've searched for this product, and I think it was only available in research settings. I've never been able to acquire this, although if I can find it, I might use it at some point. So for practical applications, we're just going to follow the acetylcysteine studies here. So again, the main side effect to worry about is perhaps bronchoconstriction. mostly in asthma patients. So here's a little bit about chronic obstructive pulmonary diseases. I don't have too many of these in my practice. We don't get a lot of smokers, but smokers will get COPD. There's not a lot of good treatment for COPDers out there. There's these, corticosteroids. They inhale them all the time. There's a lot of problems associated with that, and they don't actually reduce their mortality. So here we looked at NAC as a mucolytic. Keeps jumping around. I don't know why it always does that. NAC as a mucolytic for these COPDers. So treatment with NAC caused symptomatic improvement in COPD patients, reflected by decreased sputum viscosity and purulence and improved sputum expectoration. In addition, the NAC treatment reduced the number of exacerbations and sick day leaves in some. NAC treatment also decreased the number of viral infections and airway bacterial colonization. Now, this practically makes sense because mucus, and you can't get mucus out of lungs, it's going to be a reservoir for bacterial biofilms. So if you can get this out of these COPDers anyway, of course, getting them to stop smoking, that's easier said than done for some. Give them acetylcysteine, and it might save them a lot of grief and perhaps even hospitalizations. So a big part of my population is children. Children get snotty noses and congestion all the time. This is the biggest problem among kids. We can use this safely in children. There's a lot of studies supporting IV acetylcysteine, oral acetylcysteine, and nebulized acetylcysteine. So we're going to review a couple of the safety studies here for anybody who's worried about it. So these are pretty sick children who had ingested paracetamol. So that's Tylenol. They had Tylenol toxicity, and they had fulminant hepatic failure. So there's not a lot of good treatments out there other than acetylcysteine. And so we have a robust amount of safety data indicating that you can give acetylcysteine to small children, infants in large doses very safely. This is also kind of an interesting one about dengue fever. Dengue also can attack the liver and cause fulminant hepatic liver failure. And this was a case where they gave a 6-year-old boy acetylcysteine, and they did okay. IV NAC reduced mortality in the ICU, decreases organ failure, and decreases encephalopathy. This is, again, very sick populations here. And again, we're demonstrating the safety of these acetylcysteine in high doses. There's more here on that. We're going to skip over some of these IV. Oral administration of acetylcysteine, of course, puking. I've seen that myself. So if we give them a pill and it's like a 600 milligram tablet or capsule, the kids are going to puke it up. So it doesn't actually work very well if you try to give a kid acetylcysteine solution, a tablet, I should say, or a capsule. They will puke it up. Pyelonephritis, safe in kidney injury as well. So it's not toxic to the kidney. It's not toxic to the liver. Let's see. Okay, so here they're combining acetylcysteine with salbutamol. It's a bronchodilator. So why nebulize? NAC cleaves disulfide bonds by converting them to 2 sulfuryl groups. This action results in a breakup of mucoproteins in lung mucus, reducing chain lengths and thinning mucus. Mucolytics like NAC have been studied in the treatment of various diseases, cystic fibrosis, chronic bronchitis, idiopathic pulmonary fibrosis, and critically ill states. So over here in Pakistan, they were using nebulized acetylcysteine in children with acute bronchiolitis, and they compared it to salbutamol nebulization. Acetylcysteine nebulization was found to be more effective in improving clinical severity score and reducing duration of hospitalization. Its use was safe, reliable, and no adverse side effects were noted. So acetylcysteine, superior to a bronchodilator. Here's another study done out in Pakistan. 16% reduction in the mean length of hospital stay in infants hospitalized with viral bronchiolitis. This percentage reduction in hospital stay is low when compared with other studies of hypertonic saline used. So hypertonic saline, again, inferior to acetylcysteine solution if you can get it. This one, again, it looks at hospital stays with the kids with bronchiolitis. Again, they did better with acetylcysteine. Here, there's another one comparing or using acetylcysteine and 3% sodium chloride in the nebulizer therapy of acute bronchiolitis. So they're combining the two. It's actually kind of a low percentage. We can't get that in the States here. Ours comes in 20% solution acetylcysteine. So rational use of mucoactive medications to treat pediatric airway diseases. So there's mucokinetics and there's mucolytics. Mucokinetics improve the ciliary clearance or propulsion of the cough. Although beta agonists such as salbutamol increase ciliary beat frequency, there's little evidence that they are effective mucolytic drugs. Mucolytics, these break the disulfide bonds in the mucus, and cysteine or NAC is the only one that really does that. Expectorants, you can get these over the counter. That's your guifenascin in a lot of your ibuprofen, tylenol, cough syrups. It's no more effective than placebo in a lot of the studies out there, and many patients will say it doesn't work. Mucoregulatory. So these are the patients that swear that a Z-Pak is the only thing that ever helps them. So they'll tell you that. I've heard that line so many times. And it's because macrolide antibiotics, they decrease inflammation. So they're mucoregulatory. They decrease secretions by inhibiting mucus production and decreasing inflammation. That decreased mucin production by inhibiting the extracellular regulation kinase. Anticholinergic medications may decrease mucus production by inhibiting neutrophil elastase-driven mucin production, and corticosteroids, which can decrease airway inflammation. Of course, your prednisone also works very well for decreasing airway inflammation. And then there's the patients that will say doxycycline is the only thing that helps them. These increase secretion viscosity, so secretions that are too thin might not be well cleared either by a cough or by cilia, which is why mucus exists as a gel. Some patients, such as those with bronchuria, have extremely thin and liquid-like mucus. Mucospic drugs may improve mucus clearance in these patients. So this is why there will be some patients that will say a doxycycline works great for them, where some will say a macrolide works great. They'll say a Z-Pak, they need the Z-Pak. Only thing that helps them. But yeah, it might help, sure, but you're giving yourself an antibiotic. Why not try acetylcysteine solution if you've never tried it before? So we're going to go through a couple case reports here to put it in perspective, because I've used this thing pretty extensively. It's probably the #1 most prescribed drug for acute respiratory illness we have in the practice, even better than ivermectin, hydroxychloroquine, all these drugs that the FLCCC, identified as useful in COVID-19. For practical purposes, the mucus is what gives people a lot of grief at this point, because the COVID isn't so severe anymore, other than causing the chronic congestion. So here's a 4-year-old was sick. We used it. No bronchospasm occurred. She did well. Here's another 40-year-old female. She's reporting in. She says she felt 10 times better after doing some prednisone and acetylcysteine solution. And I asked her, well, can you tell the difference between the two? She said, yes. I'm going to use it every day till this is gone. It broke up the phlegm in my lungs immediately, and I was able to cough it all up. Before that, I was tight when breathing and was not coming up when I would try to cough it up. This stuff has stayed good for 2 years now in the fridge. It still smells like sulfur. So that's important to note there, because if you look on the vial, I have it around here somewhere. If you look on the acetylcysteine vial, it'll say like discard after like 30 days or something, and keep it in the fridge unopened. But this patient here found that it still worked 2 years later. There's some theory that the antioxidant potential degrades with time, so it just becomes like sterile water at some point. But we're finding that if you keep it in the fridge, maybe it still works, which is very good for preparedness purposes. 42-year-old female, mucus congestion, used the NAC, just use 1/4 of an ml. She didn't even use that much. The deepest and lowest part of the lungs rattled, the mucus comes out. Never experienced something coming out of my lungs so deeply. Has taken asthmatic medications her whole life, but never felt this level of a cleanse. Here's a 29-year-old female. She also got clearance of her stuffy nose. 35-year-old female. She noticed a little bit of a burning sensation in her nose when she inhaled. Some slight burning sensation in my eyes, but it started to make her cough up, which is good. She used it on her 2 kids. Used it on the 12-year-old who was sick, but not for asthma, just to clear the mucus from his cough. Very good. Working. 17-year-old female. She went to Austria on a vacation for a ski trip. She's unvaxxed, but was exposed to some vaxxed individuals. She got really sick, fever, body aches, chills, extreme congestion. She took some Tylenol and ibuprofen over there with no access to NAC. So she flew back to the U.S., cut her trip short. She came directly to me. We got her on the nebulizer. You know, we got her on this. We got her hooked up onto a mask, and she was like there. She was breathing, and she actually had to pull it off, and like the mucus was just flowing out of her like a waterfall, which, you know, she couldn't get the stuff out of her the whole week. She couldn't breathe through her nose. She couldn't lay flat on her back. She had to sit up. It was like debilitating for her. And like within 40 seconds of coming to me, flying all the way from Austria, we got it out of her. It was crazy. So some practical tips here. They're nebulizers. You can get these on Amazon. You don't need a prescription for them. There's a couple of them on there. Oddly enough, pharmacies don't keep them on their shelves anymore. I remember before the pandemic, you know, an early pandemic, I could prescribe these and they could dispense. But for some brilliant reason, the pharmacies no longer carry nebulizers like this at the pharmacy. So you need to be prepared. You need to have one, because when mucus hits, you need to have it. Every family Iron DPC is supposed to have a nebulizer on hand. And then the second is getting acetylcysteine solution. I'll try to make my screen bigger so I can show you what this looks like. So this is the acetylcysteine. And in this product, I get this from McKesson, and I always keep it at my office because I always get patients that come to me panicked. They're not prepared at all. They're full of congestion. So I always keep this at my office. But you can prescribe this to patients on Amazon. It's commercially available. Amazon will deliver it right to their door. It's easy. However, local Walmarts, Walgreens, they won't carry this on their shelves commonly. Sometimes they can order it in within like 2 to 3 days. But you know, sometimes they're like, what is this? This is, no one else orders this other than you. And I'm like, okay, everybody should be ordering this, but I'm the only guy in town who orders this thing. So with this one, you take a syringe and a needle, and you puncture the rubber stopper, and you pull out about 3 mLs or 4 mLs, and you squirt it into the reservoir of the nebulizer, and then you just breathe it in. You can do it for, you know, whatever you can tolerate, whether that's 40 seconds as that one girl, or whether it's through the full solution treatment. Whatever you can tolerate. Sometimes you need to take the mask off because the mucus will flow out. It's going to smell like rotten eggs. You're going to be like, whoa, is this bad? No, that's good. That's sulfur. That's what it is. And yeah, you can mix it with other medicines such as budesonide. If you have some budesonide, you can mix it with this. It's no problem. Or as the studies show, you can mix it with racemic epinephrine for croup, or you can mix it with albuterol if you have some albuterol. It's very versatile medicine. You can mix and match different things. It's not going to like interact with stuff. It works synergistically with budesonide or albuterol or racemic epinephrine. And so that's basically my message to all my patients. I try to like drill this into them all the time. It's like, be prepared, have a nebulizer, have acetylcysteine on hand, because when mucus hits, I mean, that's all you think about. And that's all I have for you guys today.
Fantastic. That's
Wow.
so practical. Like
Totally practical.
Yeah.
Totally
So,
practical.
Yes. And
Yeah.
so no dilution at all with the.
No, it's not a powder. It's a liquid. It comes.
Yeah, but it's, I just, concentration wise, it's fine.
Commercially available, 20% acetylcysteine solution.
Yeah.
That's how
Okay.
you'll find it at the pharmacy.
Okay.
Cool.
Mhm.
Yeah.
Nice.
Oh, that's
Yeah, great talk.
Yeah. Oh, yeah. I have lots of questions, but I want to open it up. Actually, in the chat there, Maya. Hi.
Yay, Maya. Hey.
Hi guys.
Hey.
Excuse me, talking about mucus.
Perfect timing. Yeah, so she was wondering
Contraindications?
Contraindications.
Yeah, contraindications. You know, if you've had previous bronchospasm to it, maybe you got to be careful, or you just need to use racemic epinephrine with it. Maybe if you've had an allergic reaction. I don't think I've had an allergic reaction to it. I had one, but he was using some other things at the same time. I haven't really. It's a natural medicine. It's gonna be unpleasant sometimes because the amount of mucus that comes up is unpleasant. But then they feel better afterwards.
Yeah.
Okay.
Cool. And Rich had
yeah. Okay.
He's got his hand raised there.
Thanks, Stefan. A couple of things. One is having suffered with sinus infections for years, I began to get intrigued by this wives' tale that dairy increased mucus production. And so I looked into it, and there is a basis for it.
Yeah.
Presumably there are receptors in the gut that then produce a mucus stimulating substance. And as a just a N=1 experiment, I went off dairy for a few weeks, and my sinuses cleared up. It was pretty dramatic. What's your experience with that?
I actually, unfortunately, have a lot of experience with this. My parents, they banned dairy products from the household my entire childhood. And I grew up in Italy at the time, so this means no gelato, no mozzarella, no cheese on pizza. Like, it was pretty traumatic. But it was because my parents identified pretty early on that it caused the children to get mucus plugging. And it was only until very recently that I discovered the difference between pasteurized dairy and raw milk. And now my parents and I, we can tolerate milk just fine so long as it's unpasteurized.
That makes perfect sense.
Incredible.
Perfect sense.
Incredible. The other thing is that in cystic fibrosis, I know that the concentration of sodium, for example, in mucus, in sweat, is higher than normal. And is there a role for simply intravenous hydration to try to dilute down the mucus?
I don't know, maybe Jason can answer that question. He dealt with a lot of cystic fibrosis patients, and he worked in pulmonology over there in the West. Are you there, Jason?
Yeah, I'm sorry, what was the question?
Whether intravenous hydration makes the mucus less viscous.
In the cystic fibrotic patient?
Yeah.
Yeah, absolutely. There's some efficacy in hydration there. But the NAC was a very routine treatment, part of the treatment plan for most of our kids with the CF, with more of the lung affected type of CF. But yeah, the hydration absolutely would help thin the viscosity of the mucus. Absolutely.
And Stefan, did they say that you were a tennis player? Is that true?
Yeah.
Well, where did you play?
I mean, I train every day. I mean, I just got back from the tour. I played the grass court national championships in Rhode Island this Monday.
That's super.
Yeah, and I was in Boston this past week, and I got to the finals out there in a Boston tournament.
Very cool.
I'm, of course, an amateur player. I'm a very big fan of the Flagler Saints, who were runners up for the Division II finals, national championships this past year.
I see. Oh, that's great. No, I'm still pretty active in it. Still compete.
Awesome.
Very good.
Very cool. Very cool. Kathy,
Dr. Boyles,
Dr. Boyles, a pediatrician. She has two comments. One was, is it an injectable form that you're ordering?
Which kind
for
of
the
showed,
NAC, which you
showed
kinda
us, but I
showed
didn't
us.
know if you had any.
Yeah, it
comments
comes with the
about
rubber
that.
stopper that you have to like punch off the
Yeah.
metal and you draw it out.
Yeah. And then also she just cautions about the racemic epi can result in rebound when used for croup kids.
Yeah.
So, can you kind of expound on that just a little bit, Dr. Boyles? You're saying rebound, like bronchospasm in kids?
Croup is not bronchospasm. Croup
Oh.
is laryngotracheal bronchitis. So it is in the throat at the vocal cords. So if an adult gets croup virus, which is parainfluenza virus, we get laryngitis. But because in babies and children, mostly infants, your airway is quite small there. So it does not take a lot of inflammation there for the airway to close off. Hence they have stridor.
Oh yeah,
Mm.
take them in a hot shower.
So,
Yeah.
Actually cold air works the best.
Oh yeah, that's the one. That's right.
Yeah, cool
You're
mist
right.
vaporizer.
Been a
When I
long
was a
time.
resident, we had one whole aisle in the ER where they had one croup kid after another, and we'd all break out. We had these cool mist vaporizers that we'd sit in front of the kids, and they'd be stridorous, and then 15 minutes later, they were great. But you do have to be careful. That used to be that if you had to give racemic epi, we have to admit them to the hospital because of rebound.
Oh.
Then they basically said, well, as long as you watch them for a number of hours, because once the racemic epi wears off, then they can rebound and get as bad or worse than they were to begin with. So the other thing I want to caution you, if you're taking 3 milliliters of NAC, okay, I would probably do it. This is my personal preference with 32 years of experience, but I would probably do it separate from adding any other medication in there. And I would do it 2 separate nebulized sessions because that would be 6 milliliters in that little cup. It will take 45 minutes for that to nebulize. You will be sitting there for a long time. And I've had the experience where the patient goes really bad, really after a while, actually, they actually had an opposite effect and started clamping down airways. So just be careful. I would probably, if you're going to do it with albuterol, I would probably do albuterol, open them up, and then the NAC to get rid of the mucus. That's just my opinion. So
No,
try it, but I don't know that I would put that much liquid in the nebulizer cup.
Yeah, I primarily just used acetylcysteine. I guess all these studies, they were very worried about the bronchospasm. So like every study is using a combination of salbuterol and it, or they just have it on hand, I guess. But I guess that's the main like concern with acetylcysteine is the bronchospasm.
Yeah. Well, here we just use albuterol. Salbuterol may be something they use in Europe, I think.
Yeah, Pakistan.
And then not to be confused with salmeterol, which is a LABA. So they're different.
but I can say too, if there's an indication for albuterol in the first place for bronchospasm or bronchoconstriction, you want to give the albuterol first, regardless, to open up the airways, and then of course use the NAC or pulmozyme or whatever might be next. But using the albuterol initially is prudent to do.
Makes sense.
It makes sense. Yep.
Absolutely.
Let's see other.
What Dr. Boyce, what do they do in the hospital for the croupy kids? I mean, we try to avoid putting kids in the hospital. How can we manage this outpatient best?
Well, so the very cool mist vaporizer is number one. Cool air, take them outside. And when it's, you have 2 seasons for croup. You have November-ish, the winter season, and then you have a spring croup. So if it's cold outside, you bundle them up and take them outside. And a lot of times by the time they get to the hospital, they're not striders anymore because they've been out in the cold. So, and then the second line is really Decadron. And so this is just general pediatrics.
Yeah.
Way to do it. So the Decadron is 0.6 per kilo. And we used to do it injectable, but that causes a lot of anxiety in the children. I had one kid just, close their airway off right in front of my eyes and drop. So that's kind of bad to give them a shot when they're already got a small airway and they and that's it. So what you got to do is we can actually, I use the Decadron that's the 4 milligram tablets, and we crush it, put in applesauce or yogurt or something.
Yeah.
The other thing, and I do it for 2 nights because you always get a phone call the next night that they're bad again. So even though the directions always say, or the standard is just do it once, I do it twice. Then the next thing is racemic epi. So it's kind of the third line if you really have a bad grouper. So it's definitely not the first thing that you go to, because it's going to shoot their, heart rate up, and they're already mad, and now they're crying even more. It's just, yeah.
That's great. Great dialogue.
Good tip on the crushing the dexamethasone tablets, because otherwise, if you order it in a liquid, it's just so much liquid.
Yeah, because it's 0.5 milligrams per teaspoon or something that you'd have to take 5-10 teaspoons. So
yeah,
what you can do, here's a trick, is you can order the injectable Decadron, and it's much more concentrated. So it's like 10 milligrams per mil, and you can give that to them by mouth. So I don't think it tastes bad because I've gotten lots of kids to take it. So you do that in the office. So you have injectable Decadron available, but you draw it up according to the weight and give it to them that way.
Ah,
But if you're writing a prescription, you always use the tablets and crush it, put it in something, and chase it with something sweet to drink because it tastes very bitter.
I like that.
Good. Nice.
And this, yeah, this was a previous question, the difference between standard epi and racemic epi. And then I think, Dr. Salibi, is that what you put the article there on? I'm not sure. It was a PubMed article, yeah. Or maybe it's on it's regarding NAC with Nebulized. So we'll have to look that up. So feel free, anyone, to copy that link that he so kindly put in there.
Well, I've used racemic epinephrine for years, but that's the inhaled form of it, is the racemic epinephrine. And if the regular epinephrine is the injectable that you use for, anaphylaxis and
I got it here too.
The rest.
Looks like this.
so so the racemic epinephrine is what we always use for nebulization. You don't nebulize the other one. And exactly the chemical reason why I don't know.
Makes sense.
Yeah. Let's see, what else was there other?
Yeah, I don't think any other specific questions, but I really like that. If there's,
Yeah, I like, again, Stefan, thanks for the, just kind of, you gave the science, and which was great, but you spent a fair amount of time on the practical side, which is always helpful. It's nice to think about, well, how do we do things? And then you hear a different approach. And I think that only just, makes everyone's kind of their armamentarium a bit wider and how they're providing a care or service to people. So I think it was, well done. So I appreciate it. Those comments are great.
Thank you. Yeah, I'm very practical.
Yeah, it's good. It's
you
great.
have to be able to use it.
It's a good example, Avery, of a truly safe and effective treatment. I mean,
right. That's right. Yeah, that's good. That's good.
I mean, we have to get the most out of them when we find them. And they're so rare.
No, it's good. That's good. Okay.
And are there any patients that you recommend, like I mean, I know you said that you had the one that takes NAC and the glycine nightly, orally, but any that do nebulize on a regular basis? Or
no, I only use it for the mucolytic purposes, not as a daily supplement.
Yeah.
I just wondered if there's some people that are, there's so much going on with them from a chronic standpoint that they do it regularly. Like,
I mean, that's an idea. I mean, the lung is a sponge for medicine absorption. So it's a fantastic delivery mechanism. I mean, I think there's like 170 times more receptors in lung for glutathione and NAC than anywhere else in the body. So it makes a lot of sense to deliver it that way. I mean, it makes sense if maybe you have a patient who can't do an IV or doesn't want to take it orally, nebulize it if they need acetylcysteine.
Yeah, I think that's fantastic. It's just great.
By the way, I have experience using NAC for liver failure, in acetaminophen toxicity.
Yeah, right.
We would get consulted on those cases every single time because we usually dialyze them. So it was pretty impressive, very effective.
Wow, good.
Very good.
And then just a question from Dr. Morrow. Nice to see you. Any experience using the acetylcysteine in post-COVID pulmonary fibrosis?
I have a patient with idiopathic pulmonary fibrosis, and he's used it before. He likes it. But the COVID pulmonary fibrosis, I don't know. I haven't had too many of those. Maybe one, but I used a peptide for it, and it worked.
Oh, great. Great. Yes, and a request here. If you could speak for a moment about methylene blue, such a game changer.
I mean, that's a whole nother lecture, but
Yeah. I know.
I'm still doing a lot of research on methylene blue and trying it out. It's an NAD recycler, and it works very well in those with mitochondrial problems, mitochondrial deficiencies. It's almost like a diagnostic tool. So if you think somebody has like a mitochondrial energy problem, you give them methylene blue and the red light therapy, and they'll tell you it works. Otherwise, people are like, I don't feel anything. My urine turned blue.
Mhm.
Yeah, interesting.
Yeah, that's a very good way to do a rule out.
Yeah.
It's a great one for any sort of oxidative stress disease, you know. And we use it in COVID all the time now.
Hey, one of the things I just want to mention, just so, and some of you know, most of you might know, is just that, I'm hearing the education, I'm hearing unique ways of using naturals. And I just want to throw in that the white at the prior lecture, some of you were at that you were on, is White Stone Inn in Paint Rock, Tennessee, is where actually we're going to be building the headquarters of the Body Healthcare.
Oh, wow.
And it's amazing. And we have a lot of support. A Give, Send, Go. I put on the on our signal, and I just want to let you know that. And we have the Trump Foundation, Bob Trump, right? Robert Trump Foundation is behind us in support, and so it's amazing. So we actually also just purchased. They purchased, and we're part of it, a block-long building for education. So Rich, medical school, and also JP, post-grad, get ready, because we have a physical plant, and we already have, just so you guys know, also some medical students in North Carolina that have been disillusioned that want some training. So for all of you guys and gals who are interested, obviously you can talk with Rich Ammerling, and you can talk with JP, and we've got some great NPs and nurses who are interested in fostering that whole process. So we're going to be doing a lot of work in Tennessee.
No, that's great.
I'll throw that out there. So
yeah, I'll come check it out. It's not too far from Florida.
Cool. All right.
We'll have to take in, that is for sure.
Yeah, we'll take you guys up on that, but just FYI, so more to come.
Great. Congrats.
All right.
Anything
And
else?
Does that mean you guys are moving to Tennessee?
Well, we're doing part-time. We're actually going to be doing some treatments November 11th there. I'm sorry, November 7th and 8th, and some educational sessions on true dose and ozone, just to kind of start to build the awareness in that area.
So, ozone, good. I'm
Yeah.
interested.
Absolutely.
So really excited.
Very exciting.
It is.
I like the glasses.
I know that whole look there. is
Very
really
nice, Maya.
You guys,
Very cool.
don't make me laugh. I'm gonna cough. It's so good to see you. I had to hop on. This guy here, he's great. Stefan, love him. He's my doc here, in Florida.
cool.
Yeah, when I saw that.
Yeah, I saw that was really cool.
Yeah. And then Donna here, she's like, works at my pharmacy. I'm like, she's my good friend.
My sweet girl.
Party guys.
That's great.
Cool.
Hey, Stefan, where in Florida are you?
I'm in Melbourne.
Okay. That's a great place. Cool.
Yeah.
Very cool.
And Maha, how about you? Where are you?
I'm in Brevard County, the same county, but I'm on Merritt Island, which is by Cocoa Beach,
Okay.
Base Coast here. Yeah. We're trying to recruit Kathy as a pediatrician to come down to the Brevard County. I feel like we're this close.
Yeah.
There's a high demand. We got a lot of great people that are seeking better healthcare. So they're very awake out here, and I know Stefan, his practice has grown exponentially because people are wanting real health.
Yeah. I mean, we're growing so much. I mean, Jason's getting so busy. I mean, we're just, it's out of control. I mean, people really need this sort of healthcare. We're just going to keep growing.
Cool.
great.
That's
That's
good.
great.
Yeah.
That's awesome.
Absolutely.
I'm
Absolutely.
starting a speech center down here.
Oh, congrats.
Kev
Oh,
just
cool.
bought a building, so he's remodeling that for the dental office, and we got space in the back. So we're going to be paired up. He's going to be doing dentistry. I'll be doing speech, and we'll probably combine OTPT back there too. So do a multidisciplinary approach.
Nice.
Yes.
Congrats.
All right.
Yeah.
Very cool.
Excited for everybody.
Yeah.
All right. Well, just as a reminder, putting in the chat there for CME CEU credit, we have the link there, www.eads.com/EM/9387 for tonight's activity. Fill out a brief survey and get credit, and then definitely join us for any one of our many sessions for CEU credit or non, but wonderful to see everyone.
Right,
And
very
just,
cool.
yeah,
Well,
thanks so much.
Let me put in a
Great.
shameless plug for my talk on renal bone disease.
Yes, please.
Friday at noon Eastern, right?
That's right.
Yes.
That's right.
Thank you so
That's right.
much.
It will be an overview like you've never had before. And I will also get into this whole question of bisphosphonates.
Oh, yeah.
Okay.
Oh yeah.
Good.
Yeah. We will
Nice.
try to avoid any blows.
We'll have to all the rules. We'll start the
That's right.
the rules of combat early.
That's right. Take it outside. I'll meet you in the back alley. Yeah. Dr. Aaron, very good.
I don't care anymore. I really don't. I'm
Right.
so fed up with pill pushing doctors who are, poisoning patients. So
Yep. That's right.
I'm not going to be polite anymore.
Yeah.
And that's why you're invited.
That's right.
To the
Actually,
party.
So I was at the AAPS meeting last week in San Antonio, and one of the talks on the last morning was by an endocrinologist who was a former board member who I know from the board, and he was pushing Ozempic for weight loss, and he really, and he didn't say a word, and for diabetes, of course, too. He didn't say a word about how it's so easy now to reverse type 2 diabetes with a low carb diet, and that should be the standard of care. So he didn't put up any financial disclosure, right?
Oh.
So while he was talking, I looked him up on the Open Payments site, and he was getting like $50,000 to $200,000 a year from Lilly, who makes a GLP-1 agonist, and others. Okay, so in the Q&A, I called him on it. I said, you didn't put up a financial disclosure page. Would you like to make one now?
How'd that go?
Oh, that's great.
Such a kind invitation.
Yeah.
Did he take you up on it?
I had the numbers. I had the, oh, it was a sweet moment.
I bet you.
Wow.
Good for you.
That's awesome.
Somebody's got to stand up. That's wonderful.
That's right. Oh, well, Nancy Lefebvre, Dr. Lefebvre, you are welcome for sponsoring the CME for AAPS. We are proud sponsors.
Yes, proud sponsor.
Working in the pharmacy, we get patients all the time asking for Ozempic, Mounjaro. And as a nurse, I'm like, can we just talk about what did you eat today?
Yeah.
What did you eat?
Yeah.
And I try to let's talk about food. Let's talk about movement. Do you know the side effects of this that you want? Do you know how expensive it is? Do you know what will happen when you stop using it?
Wow.
It's crazy.
Yep.
Crazy.
It's really a scandal. Really is.
Yep.
Yes.
really is.
Agree.
Wow.
Yeah, the
American
pediatricians are
Academy
pushing
of-
it on kids. It's absolutely horrible.
Sickening.
Oh.
Wow. Okay, well,
Lots of
Lots
work
of prayer.
to do.
Work and prayer.
Yes, for
wow.
kingdom on earth here.
That's right.
That is what we are trying to do here. Wow. Okay, on that note, we are definitely have all of us have our work cut out
That's
for
right.
us. So thank you, thank you,
And
thank you.
it's officially my bedtime, so. good
Yes,
night,
Okay.
exactly, exactly. Thanks for the
Great.
great discussion.
Great
Wonderful
discussion.
talk.
Wow.
Thanks, Stefan, so much.
Thanks, Stefan. Hey, thanks,
All right.
everybody.
Stefan.
Have a good
Thanks,
night.
Stefan.
Good night.
Good to see
night.
everybody.
So
See
good to
ya.
see you.
Yay,
Yes.
Maya. See ya. Bye-bye.